Okay, recording has started.
Okay.
I'm gonna begin.
Yeah, you can begin.
So yeah, most of the graphs and charts are not that much different from the last time, but I changed the orders into another format. So lung transplant to lung cancer patients,
Everything.
this is the topic. And I'll start with what do publics think about this? So last week there was a post about lung transplantation to stage 4 lung cancer at the sensiblemedicine.com. One of the journalists posted this article. His name
No,
is,
he's not a journalist. He's a UCSF faculty.
yeah, I thought he was journalist, but he turns out to be doctor, so I was surprised. So yeah, he was
Yes.
a doctor and he posted
Got a
posted
chance
a
to meet him.
posted a article
Yeah.
about lung cancer.
There's a background noise. Can you mute?
I think it's Dr. Wu. Dr. Wu. Thank you.
Yeah, so he wrote a post about one of the patients about the Vanderbilt University. So there was a cancer patient at Vanderbilt University. She was about to get a lung transplant, but insurance company declined to to compensate for her lung transplant fee. So Vanderbilt University did not proceed with the procedure. So there was a whole bunch of Twitter tweets about what is more outrageous: doctors willing to perform double lung transplant for lung cancer, or insurance company unwilling to pay for a medical center who is doing the double lung transplant for lung cancer. So many doctors claimed posted a lot of tweets. Most of the tweets are saying that, you know, exchanging one disease for another, poor survival and worse quality of life. And this is a transplant for aggressive and incurable cancer. Most of them saying are they don't even know, they don't even do the references. They're not even giving us uh, exact numbers, why these thoughts are clear. So yeah, even the UCSF faculty, that guy ma- wrote a long article, but most of them are not does not have clear reference. He says that like 100% of the time there are disease outside lung. So we can't. We did the research, so we know that 100% that is wrong. So yeah, he says that no credible data has been generated for other lung patients too. So this is also wrong too. So that's what the public thinks about. So doctors are thinking majorly about two things. Number one, why do we give lungs to old cancer patients? Why just give those lungs to younger cystic fibrosis or COPD patients so that new lung can function longer? And number two is, even if we are successful in the early post-transplant stage, there will be recurrence if you continue the immune suppression therapy. So main questions to consider are event-free survival and overall survival between cystic fibrosis COPD versus lung cancer. Which one is longer, and how should we approach this? Number two, is immune suppression bad? Is it that bad so that we should not do the transplant on lung cancer patients? And number three, how are the dream patients doing? How are our lung cancer, double lung transplant patients doing? So these are the major questions that doctors want to ask us. So question number one, event-free survival versus overall survival. Uh, Event-free survival and overall survival versus these two diseases. And I'm gonna also introduce about surgical techniques.
So Andrew, stop right there. So event-free survival, what do you define as event?
We define as recurrence of lung cancer.
So
In lung-
for COPD, what is EFS?
Uh, so I thought we were, thinking about, doing even if we do the transplant on COPD or cystic fibrosis, the event is going to be cancer arising from that patient. Um, if
So
I'm
in that
wrong,
case, you cannot call it EFS
aha,
because event never happened. So you cannot say event-free.
yes,
They never
I
had
get it.
cancer in their life, right?
Yeah,
To be able to call it event-free, you need the first episode. And then from that episode, measure how long are you free from that event. Do you understand?
I get it. Yes, I understand.
Okay. So it's a parameter, hard to um compare, but you can word it differently. So let's say when somebody develops lung cancer after they get transplanted for bilateral lung cancer, just like Albert Curie. Let's say they develop lung cancer and
Yeah,
we biopsy it. And for Albert Curie, the lung tumor had a shared truncal mutation, and it was of same histology, which is mucinous adenocarcinoma. So we strongly speculate that it is recurrent tumor. But in many cases, we don't know. Is it recurrent? Is it not recurrent? Is it de novo? Sometimes we are never sure. In many tumor boards, that's what we talk about. Is this a new primary? Is this recurrent? Sometimes there are gray areas. So knowing that, we can all lump that together in the category of post-transplant lung cancer, whether it's recurrence or whether it's a new primary from under the influence of lifelong immune suppression. We don't know. We simply don't know. But all we can say is after transplant, lung cancer happened. So you could say time from transplant to the occurrence. We're not going to say event-free or recurrence. We're not going to use that wording, but to simply time to post-transplant lung cancer, and have that as an outcome, and see if there's a difference there. Okay.
yes,
And then
I get it.
the
Thank
one
you.
more outcome is having cancer affects our immune system. Now, usually with widespread cancer, our immune system is suppressed. And that same immune system is going to affect organ rejection. Okay. So a lot of times the lung, the life expectancy of the organ, new lung that got transplanted, will be more influenced by not cancer, but by the acute or chronic rejection. So the risk of rejection, is it any different if you transplant lung with cancer indication versus non-cancer indication? So that's another endpoint people are interested in. Okay.
Yes, sir.
Okay. Keep going.
Yep. I'll fix the terminology later.
Okay.
So this is so if we look at this chart, this is a OPT and UNOS data collected chart. Well, we see that most of the double lung transplant most of the patients for double lung transplant are cystic fibrosis or COPD. Lung cancer only indicated 0.1%, so a very small percentage. So we took out that we look at the data. So if we do the DLT, double lung transplant for lung non-cancer, and if we do the double lung transplant for cancer, we see that overall survival is 5-year, 10-year, 50-27, and 57-25. And if we look at the ISHLT data, it's almost similar. So we can say that this is almost same in both diseases. If we compare the tumor recurrence, so if you look at the figure A, it talks about the incidence of tumor recurrence. So yeah, so there was 45% recurrence and 33.3% recurrence at OPTN data. And if we look at the chart, graph B, so this is the compare recurrence-free survival. And if we look at the p-value, it's over 0.05. So we can say that both data, there are not much difference between those data. So this is, if we compare the overall survival and cancer-specific survival of case series and OPTN data, we see that median overall survival is 38, and in OPTN it's 15. So cancer-specific survival and following is 48 and 27.7. So this is not that much shorter than we think. This is longer than the other UCF professor suggested. So they're living longer than we currently expected. Overall survival between patients and non-cancers, overall survival between patients who had the double lung transplant for lung cancer and non-cancerous diseases. They are in graph A, we can see that this one also doesn't have that much difference. And in graph B, you can see the overall survival is quite longer in patients with non-cancerous diseases, but not but still more than 10 years in lung cancer patients. And cumulative incidence of post-transplant lung cancer is it, it increases with years, but still that not really frequent as 100%. And if we look at the graph B, we can see that, well, still lung cancer post-transplant patients live shorter than their than the patient who had no malignancy, but still they live longer than we expected. So if we compare all these charts in the graph, so median survival for those who had lung cancer post-transplant was 51 months, and those who had no malignancy was 36 months. So these are the medians. So we can say that there are not that much really big difference between these two groups. So in terms of surgical technique, I have to talk about double lung transplant procedure.
So wait. You have to say in terms of what? Overall survival.
Median overall survival between lung cancer post-transplant and no malignancy post-transplant there are not much that big difference, 51 and 36.
So no malignancy, is that lung cancer? Is it every malignancy? What are you talking about?
No, this one is no lung cancer. Yeah, no lung cancer. It contains other skin cancers too, like skin lymphoma.
So all malignancy.
Uh, I'm not quite sure. Just uh, that's it.
See, Andrew, when you present data, you have to know everything about the data. What's in it? What did we
Sure.
actually measure? And you use the word EFS, which is not relevant here at all, right? And then you now using the term post-transplant malignancy. And you need to know the definition. What did it actually measure?
Yeah. I'll make sure I find it and edit the edited version. Is that okay?
Okay.
Yep. So double lung transplant surgical technique, there is in terms of lung transplant, there is a single lung transplant and double lung transplant. So if we do the double lung transplant, we do the right and left. If we do the single, we do just one side. And there is advantages and disadvantages of doing double lung transplant. So if we do the double lung transplant, um, it provides greater benefit to the individual patients. If we see in this chart, you can see that uh, the patient has improvement with FEV1 and he doesn't suffer that much from dyspnea. But if we do the single lung transplant, we give up those advantages, but we get the advantage that we have two lungs, so we can give each lung to each patient. So back in the back in the past, we used to do a lot of single lung transplant, and they found that if we do the single lung, many patients suffer from dyspnea. So these days they only usually do double lung transplant. So if we do the double lung transplant, we can do sequential and non-sequential way. So this is not published yet. So this is just a hypothesis suggested by Professor Ankit and Dr. Jian. Hypothesis is that there is gonna be a difference between sequential double lung transplant and non-sequential double lung transplant. So they designed the study as animal study, but they haven't done the study yet. So if we do so the original method is sequential method. So if we do the resection of the right lung and we do the resection of the left lung, we do the cardiac bypass and we get the donor lung, we put the right lung and left lung. And after that, the transplant is complete. But if we do a non-sequential way, so if we do, as you see, if we do the sequential way, we take out the right lung and after that we take out the left lung. So it contaminates. We gotta we can contaminate the other lung by seeding through the heart. So if we do the new non-sequential method, we do the cardiopulmonary bypass and extract the both lung at the same time. So we can do it. Uh, we we can prevent seeding to other parts. So this is just suggested. It's a hypothesis, and we haven't been able to do the animal study yet. The question number two from the doctors is that is immune suppression bad? So answer is it depends on which cancer you are talking about. So if we do the transplant, we have to do immune suppressive therapy. So if you suppress the immune system, there's gonna be a graft rejection because T cells are suppressed. So we uh uh we get a lot of cancers, but most common of them are skin cancers and lymphoma. So we gather the data from the OPTN and OPTN. So we we categorize cancer into 27 different cancers. So you can see that there are many cancers, even in the transplant stage. Even after the transplant, we get many cancers. The most common of them are squamous cell and basal cell lymphoma and lung cancer. And we can divide them by the year. So as you can see, if we divide those cancers by year, we can see that we can say that like year if post transplant 2 years, we get most commonly squamous cell cancer, and if we passed over 10 years, we get most of the cancers are colorectal cancer. So if we use it, if you use the data this way, we can use this chart as a screening method. So yeah, we cannot prevent cancer from growing at all. So, but we can do the we can do the surveillance for those cancers from growing. We call we divided patients by age, so we can say that between 19 to 29 between 19 to 29 years old, most common cancers that arise are colorectal cancers. But if patients are older, 70 to 79, most common cancers are squamous cell cancers. And after that, we were able to compare the overall survival between recipients who had post-transplant malignancy and who did not have post-transplant malignancy. So we uh we f- we figured out that who those who had post-transplant malignancy actually lived longer, and the reason for that is I kind of went through the details at the last lab meeting. So if you want a detailed article, you can look at that. But I'll do it briefly this time. So the reason is that uh those if so in order for cancer to grow, we need time, and as the time progresses, patients actually die from another disease, like another another like chronic kidney disease or heart failure. So if those patients pile up and those patients are classified as healthy patients, those who had did not have post-transplant malignancy, we can it creates a bias. So we do the landmark analysis, and as you can see, in landmark analysis 3 years, we see that recipients who had post-transplant malignancy live longer. But if we do the landmark analysis at like 15 year, 20 year, we see that recipients who had post-transplant malignancy actually lived shorter. So as you can see, is immune suppression bad? The answer is it depends on kind of cancer you're talking about. So yes, if we do the immune suppression, s- we cannot stop cancers from growing back. We are suppressing our immune system. But if we do the adequate surveillance of each cancers, depending on person's age and how much time passed from the transplant. So we can do the exact surveillance. And in that way, we can prevent cancers from growing back, specific cancers. So doctor's last question is that how are the dream patients doing? So our first patient, Albert Curie, was 53-year-old man who was diagnosed with invasive mucinous adenocarcinoma, diffuse lung involvement. So he was diffuse lung involvement. I'm gonna I'm gonna show you the X-ray. So as you can see, both lungs are involved. So if both lungs are involved, we cannot do like single lobectomy or wedge resection. We have to actually, if we want to cure this patient, we got two ways. Number one, chemotherapy, immunotherapy, or number two, we have to change the whole lung. So after over a year, he received various chemotherapy and immunotherapy, and uh, he clinical trials were without treatment response. So he became a candidate for bilateral lung transplant. After that, he went to ICU because his circumstances have deteriorated, and bilateral lung transplant was performed. After that, he was discharged. So this is his CT. As you can see, 1 month before surgery, there was cancers all over his lung field. After that, he was fine after all. And currently, this is 26 months post-transplantation. And at the time of 18-month post-transplantation, he had an upper lung lobe nodule. So CT find out that nodule, we do the biopsy, and it turns out to be the exact mucinous adenocarcinoma from the first time. So after that, he received SBRT, and he was cured for that nodule. So dream study, we are gathering patients. We have 3 cohorts, cohort A and cohort B and cohort C. So cohort A means that lung cancer patients who developed lung cancer inside the lung. And cohort B talks about lung cancer patients who had cancers from other parts of the other body, like liver cancer metastasis to lung. And cohort C is recently added to fulfill the unmet need of many patients. So ISLGOT confirms that any kinds of cancer, any kinds of malignancy is a absolute contraindication to lung transplant. So even those who had like cystic fibrosis or ILD, let's say that those patients who had minor lung cancer and those were treated, but they are still absolute contraindication to the ISLGOT standards. So we are also gathering those patients at core C2. So in conclusion, totally 5 patients underwent double lung transplant successfully without significant complications. And 1 patient, Albert Curie, received SBRT at 18 months post-transplantation. Yep, I'm gonna answer for questions. Any questions you want to ask?
Yeah, any question from other lab members? Please feel free to ask.
Anyone? If I cannot answer clearly, I'm gonna find out. I'll find the adequate answer and answer to you later. Yeah, I'll do my best.
Thank you for your presentation. I'm Dr. Wu. Nice to meet you guys.
Nice to meet you.
Yeah, and thank you for your preparation for the many evidences and research reviews. My question is, now how dream patients are doing is very, very, I think, important. So do you have any number, like kind of how many patients have received, or how many patients were on the wait list and they did not receive, and about how many people passed away, something like that? Because there were many evidences, but they are based on case reviews, case series. So that does not have enough evidence for, we cannot say strong evidence for medical procedures. So for that, I think how the dream patients are enrolled and some kind of preliminary report will be very important. It can, change the whole spectrum and whole current practice and idea about the lung transplant for lung cancer patients.
That's a very good question. I think I can speak into that just a little bit. So the DREAM study is up and running now. It's a little over a year since we started the project. And it's a project that's going to run for a total of 10 years. Initially, the protocol was written so that we're going to be enrolling patients for the first 5 years and monitoring them for an additional 5. And the protocol, in our protocol, we hope to enroll a total of 125 patients. So far, we've done about 15 or so cases since the start of this study. And Dr. Wu, you may be aware, but there were like about 18 or so patients that received double lung transplant at our institution previously, who've had a history of cancer that was cured. So we're going to be adding those as well. And then we have a couple dozen people who are kind of going through the screening process as we speak. For the 13 patients who received the transplant on this study, so far they're all doing very well. Albert Curie, the patient we talked about in Dr. Yang's presentation, is the patient who is currently, who currently has the longest post-op observation or follow-up, I guess. All the other patients are like, there's one more patient that's around 15 months, and then most of them are still under a year. But most of them are doing very well. We don't have any post-transplant deaths as of yet. And the idea is to monitor and build the longitudinal data from this cohort. I hope that answers your question. And if you have any more.
Yeah, so another question is, the first patient who had recurred cancer is, if we stage him, it is stage 1. Is it correct?
For the recurrence?
Yeah, I mean, he has only local region, right? One single region, is it correct?
It was local recurrence, stage 1, and treated with SBRT.
Yeah. So I think many people will ask about the recurrence of lung cancer for the lung cancer patients, but they were stage 4. But if they recur, but even though if they recur, the stage is 1 or treatable or resectable, then it should not be regarded as a event. I think it is not very different stage before the transplant. So when we follow those patients, it's very important how to define each event, because if we make event as any recurrence, then the patient will be censored on the data. Then maybe we cannot give strong evidence. But how to define the event will be very important. That's my idea.
Yeah, you bring up a really good point. So probably we'll have to have a more thorough system for defining these events so that we can have like subcategories for, as an example. I'm sure there can be other ways, and we're definitely excited to hear your recommendations or your suggestions on this too. But yes, definitely agree. I think we would need to subcategorize or subclassify these events so that they're not, these stage 1 recurrences are not being censored with like advanced cancer recurring. It's a very good point. Thank you.
Yeah, thank you.
Thank you for your comment. Any other suggestions? Okay, so let me get back to Dr. Wu's first point, which is, how many actually enrolled and was waiting, and I guess among the ones who actually got the transplant, we're just going to talk about cohort A. Cohort A, Liam, is it still 5? Or 6?
So we submitted the abstract to AACR with 7 patients. So we did a interim analysis for the 7 patients we had in cohort A and submitted an abstract to AACR, which got accepted for a poster presentation.
Okay, so it's 7 patients so far. This includes 1 pneumonectomy patient?
Yes.
Okay. So let me ask Dr. Wu. I mean, we are categorizing as a double lung transplant, but if one patient had pneumonectomy before, and it's technically impossible to put new lung with the organized pleural space, does got 1 single lung transplant, but it is the only lung patient has is the new 1 lung. And I thought it makes sense to still include this patient in the double lung transplant cohort. Do you think that makes sense?
I think it's very hard, but single lung, double lung is very different in physiology after surgery. So, in terms of cancer recurrence, he can be included in the cohort. But however, for events such as some kind of infections or any cardiorespiratory complications, he cannot be included in the subgroup because it will make the outcome worse. So maybe we can include him in the cancer specific points, but in terms of overall survival or other events like graft failure or graft infections, then he should be categorized. He should be removed from the cohort, I think.
So are you so there's the other side, there's no original lung. It's gone. It was gone even before. You so you so with the single lung, you think the infection rate, the rejection rate is worse?
I mean, the functional reservoir for any infection is very low compared to, but he was kind of before surgery, kind of autopneumonectomy status. So it is very tricky, but we need to separate them because it is technically different. Single lung and double lung is different. So yeah. Or you can say total lung transplant, then he can be included. So we cannot say double lung. So if you change the term to the total lung transplant, then maybe he can be included in the course.
Makes sense. So Liam, let's use that terminology for our analysis sake with when we include them, and talk to Perry about it too. When we include that this patient for a combined analysis purpose, let's use that terminology, total lung. But Dr. Wu, let me ask you, just in general, single lung versus double lung transplant outcome, rejection and survival. What's the general thoughts? Usually single lung is worse.
Yeah. So usually
yeah.
single lung is worse, but single lung transplant is reserved for very old patients, like over 75, over 70 years. As you know, Temple University is doing a lot of lung transplant in the United States. They last year or 2 years ago, they presented in the EA European annual meeting. They presented a very similar outcome between single and double lung, and they said it is because of their protocols and perioperative management. But in general, in general, double lung is superior than single lung. But many institutions are trying to improve the outcomes. So I don't know our data in the Northwestern, but yeah, it is general concept is like that. But they are challenging to improve the outcome of a single lung transplant, and many surgeons think it is because of how to select patients for single lung. If they select patient properly, then maybe they can get similar result as double lung.
But for rejection, is there any immunological, biological rationale that they are different?
For rejections, I'm not sure because they use same immunosuppressive agents, but risk of infection is different. I think because of the original lung has some kind of infections or low function and vulnerability, so that can be a cause of that. So people prefer double lung for young or healthy patients. So single lung was transplanted for only for some like minor candidate, like older patients who have life expectancy less than 5 or just 10, something like that.
Okay, and then your second comment was before that. So before we talk about the cancer risk and the survival, the I don't know, the quality of life or the what are other metrics that you would like to see because a lot of let's say medical, just physicians, including surgeons who do transplant frequently, they have this notion that compared to kidney transplant, lung transplant is bad quality of life, and they're still going to suffer bad, that it's really not the best option, and they still live in misery, and that you can feel that from that article that Dr. Andrews shared. Um, so what is those metrics? Like 1 month after transplant, 6 months after transplant, how are they doing? They probably don't require oxygen anymore, but what are the things you like to see that their quality of life is still good?
Yeah, so it is very difficult questions, I think. So normally compared to other solid organ transplant, because lung is exposed to, infection sources whole time, they have low outcomes compared to other organs. So it is sure. And if we compare 5-year survival, something like that, it is very, I think, different from other lung, other kidney or liver transplant. And also, in clinic or in patients, there are many patients who still suffer from, problems after lung transplant because it is related to many things. First, their functional capacity before surgery is very important because many patients who receive lung transplants, they were some kind of have very low performance status before surgery. Then maybe even though lung is good, they can have some other problem. It can prolong their hospitalization, so they can have some poor quality of life even after lung transplant. So, but in general, I think compared to 10 years ago, the outcome of a lung transplant will improve dramatically. So now in surgical society, it is gaining some foundational, some evidence about the improvement of quality and the life expectancy. So yeah, that is general concept about that, I think. It's still challenging. Yeah, but it is there are many patients who suffer even after surgery, because this is quite very extensive procedure.
But so when they say they suffer, is it more infectious or rejection, or what are they suffering from?
They suffer from infection, of course, and also rejections. Chronic rejection rate is, I'm not sure the number, so it is also another problem. And because we have not seen many patients who did second lung transplant after 10 or 15 years. So kidney, there are many who receive another kidney again and again and prolong their lives. But for the lung, we have not seen many patients like that. So.
Okay. So in your mind, what led to that 10-year improvement in patient outcome? Over the 10 years, you said there's a big progress. So what made that progress possible?
I think it is because of multidisciplinary care. Surgical technique has not been changed a lot. Just like cardiopulmonary bypass or ECMO is different, but other than that, the team care has been improved. So that is the main issue, because when they follow up the pulmonologist, their role is very important. Have early detection of recurrence or early detection of graft failure. So that is the main I think improvement. There is no kind of specific some drug or something like that, I think so.
Yeah. My patients, like every 3 months, they get wrong and look for rejection. Is that also common practice in South Korea too?
Yeah, I think so. And they do CT scan every 3 to 6 months. Yeah.
So
and we do PFT. Yeah, also
Yeah.
to see. Yeah, that makes that.
So early detection of rejection early treatment leads to much better outcome. Would you agree?
Sorry?
So early detection of rejection
Mhm.
from doing bronchoscopy like proactively every 3 months, and early treatment for any early rejection leads
Or
to
infection. Yeah, it is
Yeah,
improving the quality of surgery outcome, I think so.
Okay. Okay. Okay.
So
Hold on. Let me.
Okay.
I have to get this call. Hold on. Okay, I'm back to answer the call. Okay. So yeah, Dr. Wu, I know you were talking. Sorry about that. You can.
So I think do you have any direction for the analysis of the patients for the dream trial? I think
So
it's very it's very hard
Yeah.
to define what will be the control group to compare. So
Yeah. So that's why we have 3 different papers we published with Dr. Chion. And I know you probably got all the papers.
Yes.
We have a protocol with a dream protocol, but it's not really limited to that. It's historical control, and it's the OPTN, it's the international lung registry data. So we have full access to those 2 data set. And they have their cancer indication data too, and non-cancer. So that will be the historical control. But really, we can do within our institution data. We have our own non-lung cancer and kind of compare that outcome within our institution. Yeah. So I think those are all good. So right now, what I told my fellow to look at is time to extubation, time to off oxygen, and then there's a quality of life metrics that people like to use. But it's like time to rejection, time to cancer occurrence, time, and then survival. Those are the only things that I can think of. That's yeah, like the metrics to follow. But I don't know if you have other thoughts. Feel free to let us know. Remind me, what was your last question, Dr. Wu? Andrew, what was the last question you answered? Or Liam?
I think he was asking, I think you already answered it, Dr. Chae. Wasn't he on the control group?
Yeah.
That was the last question? Oh, okay. Yeah. So, I think so far 7 patients, all successful transplant, doing well, good quality of life, and yeah, so Liam, when you talk to Carrick, maybe even for the abstract, we can define event-free events as distant as a distant metastasis or advanced disease recurrence that requires systemic therapy or something. And because we did next generation sequencing, we confirmed that it is recurrence. But in many cases, like we don't know if it's recurrence or not. So yeah. Okay. Going back to surgical techniques. So I guess using the cardiopulmonary bypass. So question for you, Dr. Wu. So when you do sequential lung transplant, do you need can you do it without cardiopulmonary bypass?
So for sequential transplant, it depends on the function of the residual lungs. So if usually taking lung out and putting lung back takes about less than an hour, usually I think. So if it can survive for those periods, so heart and lung and survive, then they can do without ECMO or cardiopulmonary bypass. So cardiopulmonary bypass and ECMO is different term. So cardiopulmonary bypass requires more hepatinizations, and it itself has more side effects because of that. So surgeons prefer now ECMO because it is much easier to put in and take it out. And also it does not require much heparinization, so it lowers the risk of bleeding later. Yeah, so it depends, but in nowadays many institutions prefer ECMO. So
just during surgery, even during pneumonectomy, they use
yeah,
ECMO?
because sometimes the lung and heart does not survive. That saturation goes too low. So yeah.
Got it. So I think Dr. Barat's hypothesis is you take the both lungs out and totally depend on ECMO, and then put the two lungs and then do the washing, aggressive, normal saline washing of the trachea, bronchus, for a lot of airway spread, the malignant cells.
Yeah.
Then put the both lungs back together same time. That will, that's his hypothesis, is that will be the innovation that will lead to lower cancer recurrence. Do you agree?
Yeah, I think it has some evidence and supporting some thought. So it looks like that. So, but we need some data to preserve it because cancer cells, they can be in other areas, right? In other vessels other than lungs, or maybe even lower the risk. But yeah, it makes sense, but we need evidence from the animal study or something like that.
Yeah, animal study. Yeah. Well, yeah, I think what we heard is for Albert Curie, the very first patient, Dr. Barat wasn't able to do the non-sequential. They did the sequential way, and Dr. Barat believes that's probably the reason why there was a stage 1 recurrence through airway. But just FYI. And at that time they weren't doing that aggressive washing as well. Because there was like the very first case, and then from the second case, that's what he's been doing, and we haven't seen any recurrence since the second case.
So I think it can be some kind of our protocol, because many people ask about, is there any different procedure technique or any perioperative management regarding lung cancer for double lung? So that can be our suggestion and our way. So it'll be, if we build more data, then it will be enough. And for the first case, as you said, we can say this is because of sequential, that many people will agree. I think so.
Okay. So yeah. That's I think that's another important piece. Like, what are you guys doing differently? And yeah. Okay, so those are two surgical things, but medical oncology wise, I think all of us are concerned that this will come back with immune suppression, and then the data that Dr. Andrew showed, for even non-lung cancer, people who never had cancer and get transplant, post-transplant malignancy is pretty frequent. Lung cancer is also not uncommon. And showing, I guess, that we call post-transplant malignancy, PTM, is not that different between the two groups, is important. And Andrew, are you pretty convinced that their PTM rates are similar between the two groups? Are you convinced, or are you not?
I'm just saying generally speaking, I think they're one bag is there.
I can't hear you, Andrew.
Sorry. So when we did the research with Dr. Chian earlier last year, we were like 100% sure that there's not much difference between those two groups. So yeah, we were convinced.
So I know those are from K series and the registry. So comparing two groups, lung cancer. So explain what these two groups are in your table.
So this is those who had lung cancer post-transplant, and the next one was those who. So the article that I was talking about was another one. And
Okay, so this is people who developed the lung cancer after transplant.
Yeah.
This is all talking about people who did not have lung cancer in the first place. This data. So
Yeah, that's correct.
the data I'm talking about is post-transplant malignancy incident rate between people who got double lung transplant for non-lung cancer indication versus lung cancer indication. Do you have that data?
No, I don't think so. Not that one.
Okay. So I thought Dr. Jian looked at that data in one of her papers. Are you sure? You didn't see that data?
I'll find it.
I think it might have been in supplemental.
Set your SSID to point of contact. Launch your internet browser for more information.
I'll find it and put it at the edited version. I'm sorry.
That's okay. So yeah, that's the exact question that you wanted to answer, and we don't even know if there's a data for that. So the question is between transplantation who got transplant for cancer versus non-cancer, is there a difference in PTN? Right? And this is asking different question. Lung cancer versus no cancer. How long, what is there a survival difference between them? But this is all coming from only non-lung cancer indication, right? So, so Andrew, let me ask you this. Still there are many holes. You have to understand the data in that out. What's there? What is your question? So all the discrepancies that we found from your previous presentation, were you able to look into that and correct that?
Your feedbacks?
Remember, we found numbers that were different, figures
Yeah,
and
yeah, yeah.
tables.
So
How
I asked
did
Dr.
you?
Jia. Yeah.
Yeah, go ahead.
Yeah, so all those differences, I asked Dr. Jian about those things, and just like I said at the last lab meeting, some of them were errors. Some of them were mistakes. And one of them was just her article error, and one of them was we compared the wrong table. So yeah.
So can you show me what the error is and how you fixed it? So I don't want to talk about the simple errors. There are simple errors, like
Yeah.
it's the typos or those are
Yeah.
fine. But there were a very important mistake that we found. And it's all recorded if you can't remember what that is.
Yeah.
या मैं एयरपोर्टे पहुंची गया नहीं जो ये बार रात જોઈએ છે હવે આવશે જો હા આજે બહુ સ્લો છે
Okay. Let me see what time it is.
Thank you very much.
Okay, it's been more than an hour, so let's take a 10-minute break and we'll come back. Okay, and in the meantime, Andrew, you can find those. Let's take a 10-minute break. Okay, I'm back. So Andrew, do you have updates? I think you're muted.
Yeah, so I think you mentioned about this one. 5-year survival overall survival of this graph in figure 4. So this one was about 40% and this one was about 60. And between this one,
So again, when you present graphs, what are you comparing? What is the outcome? What are those two groups? Remember,
so
you're
yeah,
talking to an audience with no background of what transplant is.
so this is a graph comparing the overall survival of those who received a lung transplantation and who had post-transplant lung cancer and those who did not have post
Section
did not
council,
have
for your
any
health and safety.
malignancy.
Smoking is not
So
allowed.
So
if we
again,
look at this graph,
Andrew, again, this is malignancy happened after transplant or before transplant?
after transplant.
Okay, so you're gonna address the discrepancy first. But I thought you were gonna look at the lung cancer indication versus non-lung cancer indication. Did you look at that too? I know you're gonna talk about the discrepancy, but did you find that
Oh,
data?
uh, uh, I haven't found that one. So I was looking for this one. Uh,
Okay,
I'll update
Liam,
it later.
while he's talking about this, can you find those figures in Dr. Jian's paper in the meantime and bring it up after this? Okay, I'm in the airport, so I can't quite look for it.
Sure. Which figures exactly are you looking for?
So the outcome is survival, and the group is lung transplant patient who got transplant for lung cancer indication versus non-lung cancer indication.
Okay.
Yeah. Okay, Andrew, go ahead.
So last time we talked about discrepancy in this one. So those who had lung cancer post-transplant, those who did not have any malignancy post-transplant. So 5-year survival, if we look at it, those who had lung cancer was near about 40, and those who did not have any malignancy was about 60. So last time we thought that this figure corresponds to this table. So if we look at the overall survival of 5-year, this was so those who had lung cancer post-transplant was 40 about something. So this wasn't correct. And those who did not have no malignancy, if you look at this one is 35. So last time we thought this was some kind of discrepancy. I asked Dr. Jian about it. And she said that these two graphs are talking about different things, so they're not the same data. So uh yeah, so I thought like yeah maybe that's it. So yeah, that was the
So they're not the same data explained.
uh explaining. So So I was about to ask her about it. You know, how different are they? So I wasn't able to get a full answer for that. You know,
So again, no, just explain it to me. So this is OPTN. What wasn't that graph OPTN? Is it different data?
yes. To me, they're talking about same numbers. So yeah, 220 patients and 29,100 patients.
For
This one
staging
also talks about
purposes,
the
if you
same
are
data.
traveling with small children,
So
strollers, or large
uh,
luggage,
I'm not
please
quite
use the
sure what
nearest
she
elevator when
mentioned
moving
about it.
between
So
floors. Thank you.
I'll ask her specifically this time, maybe.
Mm. So the numbers are all different, right? Median is not 51 and 36 here, but it was 640 and 60 something, right? Median is,
Yeah.
yeah. What about 3 years and 5-year overall survival? Are those numbers all different?
Throw it.
You can do 5-year survival.
I mean, it's I think they're different. If we look at this way, they are like 80 or something. And this one is still there's it looks like the discrepancy, but total numbers are kind of the same.
So, but here, lung cancer group did better in this number, right?
Yeah.
And this is probably survivor bias, that you live long enough to develop lung cancer as opposed to some people die of rejection or some other infection complications, right?
Yes.
So this is having not accounting for those survivor bias, correct? But again, I am still suspicious because the numbers are same OPTN data, and I still am concerned there may be error. So yeah, communicate with her. Yeah, and
Ask her
if we need,
specifically.
and if we need to correct it, then we correct it, do the analysis again, and we need to send the journal. If there is a real error, then we should correct the error. You can do that too.
I'll talk to her about it.
Okay. Is this so this was the critical error that we saw. But here, so I think the direction is, the table says lung cancer versus no malignancy post-transplant. Lung cancer group did better. But go back to the graph. Here, the lung cancer group did worse, correct? So
Yes.
I think there's a huge something wrong here. And I feel like we need to address this. This is important. Okay. Now, Liam, are you able to find anything about the graph that I told you?
So I'm looking at the RR papers. So actually, it's everything Dr. Yang presented. So when we're looking for survival between transplant patients with lung cancer and without. I think this is the figure we'll be looking at. So this is comparison of overall survival between patients who received double lung transplantation for lung cancer and for non-cancerous diseases.
So A is case series as a case. B is actual OPTN data. So Andrew, you did present this, correct?
He did.
Yep.
Yeah. But why did you say you don't know where it is?
I'm sorry.
Wi-Fi services
Okay.
are available.
This is the most important data. The case series, like Dr. Wu mentioned, has a publication bias. People will only publish the good results usually. But then OPTN registry is unbiased. Well, if you look at it, there's a difference here. And this will be used by people to say, look, the lung cancer cases suck. So lung cancer. So the next question is in the OPTN data. It looks like they're doing poorly. What's the reason? Is it because the cancer is coming back? Or is there some other reason? So the next question is in the graph B, is there a difference in PTM? So post-transplant malignancy rate. And here the malignancy means everything. And can you find that graph, Liam?
So I think it will be this one.
But this is all non-lung cancer transplant. Right?
Well, it's all OPTN. Well, yeah.
Yeah, so this is different question.
Right.
So did we ever look at PTM in that two groups in figure B? Lung cancer indication versus non-lung cancer indication.
Might have to look. So we have the data. We haven't combined it to one table. So if we look here, supplemental table 1. This is cause of death in patients who received double lung transplant for lung cancer in pooled analysis and the OPTN registry. And then if we scroll up, we have clinical characteristics of patients who received DLT non-cancerous disease in the OPTN registry. So we've looked at them separately. We haven't compared the two head to head.
But in this table, is there a section that says PTM?
Not in this table.
The US has 2 locations at O'Hare International Airport.
Maybe because we didn't quite have that
Outside of security on the best
data well documented. I don't know, but
the USO is located inside security on the mezzanine level of
so Liam, look into it if Dr. Jian ever did that in any part of her paper.
all active and
For now, we'll say we can't find it, but I think what's needed is, yes, there seems to be overall survival difference that, from the OPTN registry that lung cancer cases did poorly. Now, is there a difference in PTM? Is that the leading cause? And was there a difference in graft failure? I think rejection is hard. Graft failure can happen for many different reasons, and probably is the reason for worse survival in that figure B. So the question is, between the two groups, lung cancer indication, non-lung cancer indication transplants, is there a difference in graft survival? And is there a difference between post-transplant malignancy? Everything combined. I think that's a urgent question that we need to ask. We need to answer. We need to answer. And I believe that's the question that Dr. Andrew posed for this presentation, and I don't know if he answered it or not. So let's look at that. And then you can ask Dr. Jian about it and CC me on a public communication and figure out whether we need to look at that. And if we don't have that, that would be a nice quick project, Dr. Wu, because he's is this his first day, Dr. Liam?
I think he was starting next week, but he's just joining our lab meeting today.
Oh, next week. Okay. Next Monday is his official start day?
Yes, that's that's what we discussed last time, but I'll double check with him.
Oh, okay. Yeah. Whatever the case, if we have the data, great. If we don't have the analysis, we have the raw data. So Dr. Wu can do the analysis and then present the data, the outcome in our next lab meeting. Okay. So let's work on that. Okay. Andrew, before we wrap up, do you have any questions, concerns, anything?
So I'm gonna be honest. I have a step exam few weeks from now, so I think if I won't be able to like do a lot of work. Yeah, I just wanted to tell the lab members about that. But things you mentioned about today, I'll ask Dr. Jian and CC Dr. Chae and Dr. Liam about that matter.
Okay. Yeah, you just need to follow up on those. Be persistent.
Yeah, I'll do it.
Okay. Okay, good. So this is the first presentation that you understood what I wanted, like the TED presentation, not based on the article itself. You're not going to go by table. You have to address the burning questions from people who never knew, what's actually going on. So remember that. I think you did great job. And this is how you learn. This is how you learn. Okay, so let's move on. Monica, can you update me on the things you've done?
Yes. I of
Are you with Sally?
yes, because there was nobody in the lab, so she invited me here just until
Good. Is Sally next to you?
yes, she is.
Oh, good. All right. Yeah, I figured you guys should enjoy just company. Yeah, good.
Information desks located throughout the
Our
terminals.
learning session.
Information desks are located for security in each
Oh,
terminal
it's breaking up.
and home security in
Oh,
terminal 1,
uh,
2,
can you
and 3.
see me now?
Yeah, I hear you now.
I'm working on the SOP, but I can share you my. Can you see my screen?
Yeah.
So I'm just working on the SOP. This is how far I have come along. Instead of just updating on what my part has been done, I on working like as if I'm giving a handover to somebody that's pretty new. This project, keeping each and every steps like what are we doing, what explain each and everything that's on the clinical that we collect clinical data. So I have a lot of information.
Good.
Very strategic. We look so that I have done a little bit about resist, IR resist, and how we do that.
I love it.
And requesting how we for requesting diagram, I ask Liam for assistance. But I will be adding up and also looking for the best diagram. This is what I have. If I could add a few points, I am asking Seong for her assistance too. I'm like, if there's anything she felt that could be added, and making like the research part.
Okay.
Oh, I will be stating all the links available.
I don't know why it's breaking up. Is it just me or I don't know.
Yeah.
Liam, is
Are
it
you able to-
okay? Are you able to listen well? Hear her well?
Yes, I hear Monica very well.
Oh, maybe it's my connection then. The airport. Okay, go ahead. It's okay.
So I have updated on the progress of research so on app computer. I will show this. I've just figured everything to where we can find all the DICOM files, where we can find details about what we have done and a few references anybody can look up regarding our project. This is how much I've for radio. And Uh, Dr. was out of the lab until yesterday. That's what he. I believe he must be coming back today. I will send him a quick reminder about our. He still haven't given me an exact date, but he does want to do a few things. Go ahead. Mm.
Who's he? I didn't get it.
Sorry, Dr. Yuri.
Dr. Yuri, okay.
Yeah, he has not been working this last week, so like according to him, he might be today, like in his lab today in his office.
Mm,
I'll send him a reminder and fix the date.
okay.
Other than that,
Mm,
have one segmentation which me and Liam could not figure out, which I think we can add up. Want me to like when would be the good time for you to that?
Yeah, tomorrow I'll be in the lab all day, so maybe tomorrow morning you can grab me and we'll go over that segmentation.
Sure. And apart from that, done with everything else. I've also updated each and everything in the drive.
Mm,
And now it's just I'm just waiting for Dr. Yuri and making like a final data set, finalizing everything. That's all I have left. I'm left with so far.
okay. Okay. So after you finish in our lab, did I tell you who you need to sign out to?
I've still been giving Seong signouts every often. We even spoke to her yesterday. She was having some exams, so we didn't bother her for some time. But yesterday I could catch with her, and I was able to tell her about each and every updates. I do that even like in the chat personally. So
Okay.
it's still Seong I have been able to communicate everything with.
Okay.
But is there any
So
you would want me?
yeah. So I feel like this radio mix is a big project, so I want people to know how this project is being developed, where's the data, what exactly are we analyzing and all that. So I want you to set a time, and the participant would be Liam, Sally, Dr. Wu, um, um, and I think I don't know whoever is in the lab at that time your last week.
Oh, sure.
Just give a presentation of the whole SOP. This is what has been done. So, but the lead would still be Seong because she's coming back. But I want everyone who will be kind of staying in the lab. Versus I don't think Haesung needs to be involved because she's also going to be finishing up in next 3 months. So whoever is kind of staying in our lab should be able to understand the whole process, and when it's time to divide and conquer, they already know the whole process of the project. So the plan for that, the last SOP update meeting for the lab members that I mentioned. Okay. Okay. And how are you doing on writing paper?
I have not started yet. Honestly, I've started. I read, but asking Sally has also been helping me because this is
Uh-huh.
first time doing it. So she says she will help me write, like teach and write with me, like the introduction portions. I will be starting next week, I guess, after my interviews are all over.
Sounds good. Sounds good. Yeah. scientific writing is not easy. The more you practice, better. Because everyone can write abstract. It's so short, and it's just one big result. But then to be able to articulate the whole the background discussion, what does the literature show, and to be able to say that concisely and convincingly is a difficult task, and we need to do that in a timely fashion. Like, I had one of my mentees who came here for 3 months. I told her to write a article. She didn't write a single sentence.
Oh.
And I asked her why. She said she's been reading like the background articles to learn about the field. And for some reason, it was so hard to write even one sentence. So she said she just simply couldn't do it. She left. So it's that hard. It's that hard.
Ask more lab members out.
Violators are subject to a fine. Thank
Yeah,
you.
but it's like journaling. You can't improve unless you start writing and practicing. So yeah, I would challenge you to, spend time writing it. But life is not easy. When you really need to get something, do something, there's always exam, there's always something coming up, someone's sick, or you're getting married. There's you might have to move. Uh, there's so many things in life that happens. But that's life. That's life. Life will be always like that. So, yeah. So just appreciate the opportunity. Whatever you can do. We don't blame anybody. We don't judge anyone. Everyone has different pace. Like you said, your starting point from Nepal very different than US. The culture, work ethics, whatever you do and learn, that is my focus. If you learn, it's for your benefit, for your success. If our lab could be of benefit for your success, that's what matters. You finish what you can, doesn't, no one's gonna judge you for anything. I just simply feel like my mission, the projects are important, but the most important thing is that the lab members learn and grow and help each other. We're all limited, you can't help each other if you're overwhelmed by your own personal, duties. And we have to, step up and help each other. Liam, went to emergency rooms, family members sick. Everyone has something going on. I'm here. I'm still doing lab meeting, but I'm waiting for it's like custom taking more than 2 hours now. Waiting forever. And then gotta move bags and all that. But so I'm just saying we have all personal duties to take care of. But in the midst, whatever you can, do it out of willingness. Like, wow, this is my chance to, step out and learn and help and yeah. So as long as you do that, I'll be, I think you're doing great. I'm very proud of you, and just, do whatever you can till your last day. So very good, Monica. Okay, Sally, give me an update.
Okay. Yeah. So for me, I kind of updated Dr. Charity yesterday, but this week I've been mainly working on Imagine AI, like uploading the data and kind of using the platform and see the results. Yeah, Brendan, I guess this is mainly for you too. Like, yeah, basically this is the platform that we're using for Imagine AI. But basically when I processed 80 slides into it, and out of 80, around 20 slides did not have enough issues in order for it to be processed. Through AI, so those were excluded. And then but basically the result is that most of the slides came out to be equivocal. So I think, yeah, yesterday, Dr. Chae and Dr. Liam and I, we talked about how we'll set up a meeting with Imagine AI to discuss what we found. And it kind of asked them if they could like kind of explain, you know, or update their platform if possible. And so yeah, I will also be reading over their like posters and review papers today, what's posted on their website, to see how they tested like accuracy of their tool.
Mm.
Yes. And then we'll also
Okay.
so
Okay.
If you are traveling with small children.
Yeah. Also, the tumor infiltrating lymphocytes, anything they can do, you know, like research wise, you know, communicate with them. CC me on all the communications. Let me see. Leah, what is the next upcoming abstract submission? Is that ASCO?
Yes, it's ASCO, February 6th.
Hmm. Imagine.
Yeah.
So there's we used all the images that we have, like
Okay.
so
Okay.
so.
Mm.
Oh yeah, yeah. Liam, did you respond to our new pathologist email? He wanted more information.
Yes, I actually need to get that information from you. He was asking for some kind of an account number.
So Susie has it. Just get it from Susie.
Okay.
And is that all? And then I'm just wondering, is that request? It's not going to. It's like, you remember we had the pathology committee and they had we can only request less than 100 patients and things like that.
The
Do you
one
think
a long time ago?
Yeah, a long time ago. So do you think this is something similar, or this is just a form to retrieve? Because I don't know why he requires this form. Like Alex didn't ask, you know, anything like this before. So I don't
Yeah.
want this to start another committee thing. You can do this project, you cannot do this project, things like that. You know what I mean?
Yeah, I'll check with him.
Yeah, check with him, you know, what is this form, because are we gonna, you know, why do you need a research account? Account is for money. Like, are you gonna charge for pulling? You know what I mean?
Yeah.
Are you charging your charging fee for, I mean, we now have money we can pay, but you know, if we are actually paying for this, then you know, we wanna know expected deadline. Like, you know, like we want responsibility, you know. If Dr. Alex was volunteering and he's like, you know, I'm busy and we just wait forever, right? But if it's we don't know, you know, I'm happy to pay for anything now that we have money. But then what is it? This, you know, is this for research proposal review, or is this just to a document that is required to pull out slides, or you know, and that's, you know, is this going to be reviewed? You know what I mean. Just find more about what you know, and then Susie will just give you that my research account number, or if you call it the research gift account number right away. Yeah, and then ask him, and if it's like everything will go smooth, then what's the expected? Because Looney sent that email, that they can't wait any longer. So the Dr. Easter sent the list, I think. So you know how, and then if Dr. Easter, that slide that will be scanned can also be used to be added to the Imagine AI list as well, right? So the Imagine AI list used all the Lunit slides, correct?
Yes.
Yeah. Okay. So yeah, and then that's 100 more patients. So let's do that. Because I think he's new. Maybe he can get it in next 2 weeks. Why not wait 2 more weeks and get 100 more patients and then publish that one? If we can get that added, I think whatever we get, even if a lot of equivocal, we can write it up for the ASCO. And it's just like with Garden. It doesn't matter if they like the data or not. We can still independently, present the real world data. So let's shoot for ASCO, but I wanna get 100 more slides. So work with Dr. Iser, work with the new pathologist, give him everything he wants, and get his expected, like, can he do this in next 2 weeks, something like that. So in the holidays over, we just need to really push, and I'm happy to pay. What is this account going to be used for, and all that. Just be persistent in following all these communications. Okay.
Did you want to take a look at this form, or so it's, well, let me
Can
just,
you? Yeah, you can share it on the screen.
I can't help but log it because I'm like outside of the.
so it looks pretty standard. It's a NMH pathology department clinical specimen release
I think you
request.
just need somebody to help you
The
back
request
it.
there's Dr. Batash.
I can't pass. I can't go. I'm
This is
inside the
his
building,
contact
but I can't.
info. We gave him our study protocol.
Uh-huh.
The retrospective study protocol is put here, and the research account is the one he was requesting information from. He already filled in like the project summary. It says digital annotation of lung cancer slides to determine whether future ratio predict response to immunotherapy in patients with lung cancer. I think he gets that from our protocol. The description of the material is slide review for 120 cases, and we're going from 1 to 3 unstained slides for IHC staining in a subset of patients from one selected block each case. And the next page is for path department use only. Materials requested. Dr. Batash wrote a list of 120 samples is compiled. The first phase is to slides which is the right block for further IHC staining done in path 4. Slides will be stained. And that's it.
Yeah, it looks like just a request form to me. But yeah, just to double check, all those questions I asked, you can ask those questions to him and to see me. And then like just logistically, like, you could do the same thing. Like when it's ready, you can come to pick up slides, and where do you want me to pick up the slide, and all that, and yeah, arrange that with Cooper's map, and yeah. And make sure Dr. Cooper is also listed as a co-author. He's been helping us, and then any abstract paper we write, we acknowledge him and then get his input if he has one. So when we circulate, make sure he's reviewing our papers.
Understood.
Okay. Yeah, so this is the priority this week. So let's work on this. Okay, so Sally's gonna write up the Imagine AI ASCO abstract. Let's say if we don't get additional 120, still write it up. I think that's fine. We can't compare company to company because they would not want it, and it's not commercial yet. if it is commercial, then it's fine for us to remember we did gardens and foundation comparison. We can do anything we want. I think Imagine AI is now commercial. So Sally, look into that this is commercial. This is done in CLIA certified lab that I know they allowed us to use their platform, but this is a fee for service. I think they've launched their service. So this is not research only, and this is provided for those who want. So see if it has really been launched as a commercial laboratory service.
Mhm.
That way we don't need their permission.
The US
Uh,
has two locations that
But anyway, those are sensitive things. So.
Terminal 2 is located
As
Sal,
as
Mhm.
Imagine AI, the lab is CLI certified to conduct clinical
The
laboratory.
USO in Terminal 3 is located inside security.
Yeah, so is this something that is commercial? Like is it reimbursed? Is it
Service members
This is
interdependence.
so they are providing this service to clinicians, right?
Yes.
So talk to Liam because like this is a fine belt line.
Okay.
Okay.
Other than that,
Okay.
we're waiting
Any-
on PUA for Biodex and Imagine AI updates from Evan Pearl. I will email him again today. I sent him a reminder email last week, but I haven't received any responses.
So when is that meeting happening? The legal team or
Next week.
next week? Okay. Oh, you're telling me what's going on with the variant classification? Did you sort things out?
So I talked with all the undergrads, and I also talked with Grace. So it seems like Eugene's project is so no one is working on Eugene's project right now. And then Grace's project as well. Grace's manuscript is not written at all, like not even a draft. So I think someone else could definitely pick that up. And then, but for Emma's project, I think Emma and Eileen, they are finishing things up with like editing very few things. So I think they're almost done. And the one that Dr. Union and I worked on, that project is submitted, but we're still waiting for updates.
Mm. Mm. So how far is Emma's project from being submitted?
Like very close, according to them.
Okay.
So I think they're done writing the draft. I think they need to fix a few things with statistical analysis that they're working on. So I think they just came back from break, so I think they will probably be able to do it this month.
Okay. So here's what I want. Sally, you're gonna be in charge of Eugene Kim's project. It's all written up. It's been submitted multiple times. It was rejected. So you'll be in charge of actually just submitting it and getting it sub-published. Okay. No one else gets involved now from now. It's been too much, too much. And Eugene Kim and Samantha, they are the two first authors. So your role is submit it, revise it. I mean, you know the whole science behind it. So you are able to revise it, get all the raw data, get everything you need to do the revision. I don't expect Samantha and Eugene to be involved in this project. Although they are first authors, they are busy And so it's just hard to depend on them to finish the project. Although that has to be the case usually, but I will assign that this is your role to get that paper out. And it's just consider this more administrative role. You're not writing the paper, but you have to do the revision if the revision comes. Make sure it's also printed in preprint. Okay. The next one is Grace Lee's project. I think Grace is busy with medical school. So this project has not been written up. Okay. So this is something that people who want to work remotely without lab can do. So suggestion, number one, Dr. Uni Choi. She got matched. I don't think she has like an active project right now. So she's more than happy to write this up and be the author. Maybe like co-first author for this paper. It's almost same thing as she wrote up, right? So offer that, CC me and all that communication. Just talk to her over the phone first. Offer that. If she said no, I'm too busy, I can't take that on as a project. Then you discuss with me for people who are asking for remote projects. You can talk to Dr. Chuhi. She wanted remote project. You can talk to Dr. Ellen Cho. He wanted remote project. You can talk to Brandon. You can talk to Aranus. You can talk to anyone who wants to work with remote data set that is not Northwestern patient data set. So you can talk to all these people, engage their interest and time commitment, and let me know about this project. You don't have to work on this. We will assign, but people who have done this project like Uni is in the perfect spot, and you are more than welcome to help them, and then participate in some small part of the project. But you are going to be involved in multiple projects, so there's always priority. But this is the least of your priority. Your role is to make sure someone is already working on it, and your role is facilitating. Like, where is it? Are you working on it? What's your deadline? Your role is more enforcement. First one, you are the gonna be in charge of publishing. Second paper, you're gonna help facilitate. Third is you're the facilitator. Make sure Emma is working on this project and submitting it. Fourth, just work with Uni to get it published somewhere. Okay. So, but still, you're in charge of all 4 projects. Let's work on it. It's been too long. And then, in the same token, along with Liam, but I want you to be the lead. There's a pacemaker paper. It's I think it's been too long, and I think we have to publish it. Have you been involved in writing, or you haven't?
I have. So I wrote the intro and everything in few things, but so one thing about that, Dr. Leah, so as I was having a meeting with Grace, we looked at it again yesterday. And I remember you said last time how we need to shorten the manuscript, but the word limit was like 2,500, but I think our word count was around like 1,000 something. So like, is that still something we need to work on?
It's down to 1,000.
Yeah, it's like 1,500 something. It's much less than
Show
2,000.
it to me later, because last time I checked with them, it was like 1,500.
Because body is like everything else except the actual, right? Yeah. So yeah, we did see, yeah, when we counted, when we highlighted counting, like yeah, there were less than 2,000 words. So I think it's ready to be submitted.
Okay. Let's go over it together later.
Yeah, if okay, hold on. Let me answer this.
Meanwhile, I can show you while Dr. Chae is in the.
Actually, can you 1 second, Sally?
Yeah. Wait, I can't hear you. Oh, you're calling.
So dark. It's
Yeah, I can.
Hope you're doing.
I missed you.
Oh, oh, he left. Hi, Brendan.
Hello. How's the weather in Chicago?
Rainy.
Oh, it's raining?
Yeah.
all day since when?
I
I know it's
see.
cloudy today. What about over there?
We have a snow day today, so it's like been snowing all day and like everywhere is like closed, and Kansas City snow days is not as bad as compared to Chicago snow day, but still a decent amount of snow.
But you get snow days, like you got school off?
Uh, Technically, I think our school is if we have like clinic or something, we're off, but then if we have like classes, I think they're virtual.
Mm.
Yeah, but I have no classes or no clinic today, so I'm technically off like no matter what, but I
Right.
want to like go to places and restaurants, but a lot of them are closed today just because of the snow.
I see, I see, I see, I see. Makes sense. Makes sense. Did you start school?
Yeah, yesterday was first day of class.
Oh, fun. Yeah, but Brendan, if you wanna, what Dr. Chae talked about earlier, if you wanna work on the variant classification project, you can always reach out to me. The abstract is submitted and we're done with like data analysis, but we just have to write up like the manuscript.
Mhm.
So have you written a paper before?
Yeah.
Okay. So like you can definitely work on, it might be better if like Dr. Uni, who knows like the process, like the method and stuff like that, maybe she can work on like the discussion and analysis portion, and then you can probably maybe work on introduction if you're interested.
Mhm.
And she has time, maybe. And so like the introduction, like honestly, we have 3 other manuscripts very, very similar to this project that you can honestly just like look at it and rephrase, paraphrase, like, and find maybe few new citations. So it will be honestly a very simple task, simple writing. So if you're interested, let me know. And then
Yeah, I'm interested. Yeah, if it's like pretty similar too, like then I assume the methodology I could also write if you need me to as well.
okay, sounds good. And then the Imagine I will keep updating you on that as well to see if I can, yeah, if there's anything I need help with. Because I think from today's meeting, we will be getting 120 additional data slides. So we'll have to like run that through the platform.
All right.
Yeah, but I'll also ask them to give you access because I think they need to give you access to the platform. So yeah, I'll keep you updated. Can you just leave me your email in the messenger?
Yeah, I could send it to, oh, message. And so then I could just, I guess, meet with you and discuss more about that once you're ready, and then
Yeah.
talk more about the variant classification.
Mhm. Meeting.
Thank you.
Yeah, once the slides are here, then we can set up, yeah, the meeting and then figure things out together.
So,
And you can help me write the abstract if you're interested as well for that one, Imagine AI.
yeah, sounds good. Just let me know when we can meet, and then once I get all the information, then I can work on it.
Okay, sounds good.
Are you guys outside of the lab today, working virtually?
Kind of, not really. We're gonna go back to the lab later, but we're just here because Dr. Chae is as you heard him say, I missed you. His family's coming back today. Came back today from Korea, so he's like picking them up. So he won't be in.
I see. And then Will left today?
Well, left last Friday, right? Yeah. Yes, us two, and then Dr. Liam.
Oh, no, Hazel?
She has, I think she has interviews. Yeah.
Sally, can you hear? Am I audible?
Hi. Yes.
Yeah. So Sally, I just I was listening to Dr. Chai, and he said like we should collaborate on the one project. So I would like to collaborate. So can you tell me more about it, and like can I get access to like Google document and stuff? Because I'd be willing, because I have time, so I'd be willing to like write down any part that you want me to write.
I see. Yes, yes. Wait, when are you coming again? What date?
See, my country has elections now, so everything is like postponed, unfortunately for me. So they give me an interview in February now, which was scheduled in January. So it's just like it's getting late and late. So I just want to like work till remotely till then. So
Okay.
I don't know. So it's like weird in our country.
Okay. Yeah. You're also welcome to work on the project as Dr. Che suggested you, Brendan, and a few others. So I don't know if you can, I think she's okay. Can you hear me? Can you hear me?
Yeah, I can hear you.
Oh, okay.
Yeah.
So yeah, so I will first talk with Dr. Yuni because yeah, she knows, she worked on the other project that's very similar to this one, so she knows the most out of all the list of people that he mentioned. So once she says yes, you guys can definitely help her out and delegate different sections to work on. So I will definitely let if she decides to write it, I'll let her know that you're interested and you and Brendan are interested. So you can be part of it as well. Yeah.
Thank you. Dr. Liam.
No, she's done. You're
Dr. Liam, can you hear me?
Ernest, your sound is like very, very low. Very low.
Oh, can you hear me now?
I can hear better, but I think Liam
Okay.
maybe
Dr. Liam, can he hear me, or like is he on, or did he
maybe
leave?
he's just doing something like maybe short bathroom break or something, but he'll be back.
Okay. Because like I had to discuss that we are working on this project, but it doesn't have like any proposal, so we were just like working on it. So we had to discuss this with Dr. Chai today, but like I think he texted that we will continue the hour meeting in 1 hour, and it's like 10 p.m. So I might not be available by that time.
Right. Oh, good question. Did talk like did Dr. J say that? Are we continuing in an hour now?
Yes.
He did text it that?
Yeah, in Messenger group, he updated
Oh,
that
in an
he will
hour?
resume in 1 hour.
Okay, perfect.
No, she's gonna, it's pretty late.
Oh,
for
okay,
her.
then she can. Yeah, then you can watch the
You
recordings
can-
later.
And no, she has things to discuss.
Oh, things to discuss. Oh,
I mean, you can do it tomorrow too. Dr. Chae is like free
let me